Good evening and welcome to Wednesday Wellness for Women, brought to you by IHA and St. Joe's Medical Group. Tonight's topic is this the new me? Pelvic prolapse and bladder dysfunction. Our presenter tonight is Dr. Paul Makela, a board-certified gynecologist who specializes in urogynecology. Just a couple housekeeping items for all of you. Your cameras are turned off, your video is off, as well as your sound. You are all muted. If you have a question, please type it into the Q&A at the bottom of your screen in Zoom, and Dr. Makela will address the answers at the end of the presentation. Lastly, you will receive an email in the next couple days with a link to the presentation as well as a recording of tonight's presentation. So if you missed something, don't worry, you will have another opportunity to view the presentation. So without further ado, Dr. Makela.
Good evening. I want to thank everybody for taking time tonight to be present for this topic that I think is very important, very timely. It's certainly a problem that's very common, and it's certainly increasing. A little bit about myself. I am a board certified OBGYN. I limit my practice to the practice of gynecology and particularly specialize in urogynecology. I trained at Wayne State University, went to medical school there, did my residency there, and then was an attending there for about 14 years in the division of GYN surgery for a good portion of that, and then was private for a period of time. My practice has always been heavily aimed towards gynecology, and urogynecology has become an increasing component of my practice over time as the problem has increased. It's estimated that 31 million women in the U.S. currently have some sort of pelvic floor disorder, which is pelvic organ prolapse and bladder dysfunction combined. And one of the more recent numbers we have is 367,000 surgeries related to prolapse incontinence in the last year. That number, it wasn't many years ago where that number was about 200,000. So the numbers keep increasing. So I'm going to start the presentation here in just a second. I'm going to stop my video, and then when we get to the end of the presentation, I'll open up my video again, and we'll talk about questions. So the first thing some patients don't understand, or some people understand, is what is urogynecologist? And essentially, it's a melding of urology and gynecology. When I was a resident, the urology clinic at Wayne State didn't accept women. It was kind of a lot has changed. Some of those urology programs that didn't accept women as patients kind of spurred the creation of urogynecology. So gynecologists became trained in urology type procedures. Today, it's changed even more. Urogynecology can come from a urology program or a gynecology program. And so we see both now, and there's a little more cohesion. It's certainly a benefit for patients. So a urogynecologist is a doctor who specializes in diagnosis and treatment of women with pelvic prolapse and bladder dysfunction. There are certainly some generalists that are very well trained to provide care in this area, but sometimes it gets, some OBGYN doctors choose not to practice this area. And, others will do certain procedures, but not others, and typically urogynecologists is going to offer pretty much all the procedures that might be needed, or all the treatments that might be required by a patient. So pelvic organ prolapse, we call it POP for short. What is it? It's essentially changes in the pelvis caused by loss of the normal supporting structures of the vagina and the pelvis. The body parts that we find in the pelvis include the vaginal canal, the uterus, the bladder, the urethra. Some portions of small intestine actually reside in the pelvis, but largely are in the upper abdominal cavity, and then the rectum. there's basically two things that provide support in the pelvis. The number one source of support is connective tissue, and then muscles. Loss of support occurs when connective tissue and or muscle is damaged. It can be stretched, it can be torn, weakened in some way. Our connective tissue naturally weakens as we age. And we'll talk a little bit more about this, but essentially the connective tissue and or muscle weakens and allows body parts to start moving into areas that they're not meant to be. And predominantly that's into the vaginal canal, and then in many cases through the vaginal canal. We'll have some pictures coming up. Once I start talking to a patient and we start talking about prolapse, I tell them they do have prolapse. The first question they usually say, well, why? And it really is what puts them at risk. The first thing to understand is pelvic organ prolapse is common. Like I was telling you earlier, 31 million women are estimated to have it. It definitely increases after pregnancy and as women age. We think vaginal delivery is pretty probably the number one reason why people have prolapse, but that's not to say if you are never pregnant that you won't have prolapse. Vaginal delivery can definitely damage connective tissue, muscles, nerves that provide support in the pelvis, and then allow prolapse and bladder dysfunction as well to occur. And today we're starting off with pelvic organ prolapse, and we're going to end with bladder dysfunction. The two are kind of go hand in hand in many cases. You can have pure bladder dysfunction, no prolapse, and vice versa, but more often than not, you have a little bit of both. So certainly vaginal delivery can cause damage to tissues and muscles, and then there's a genetic component. Not all connective tissue is the same. We know there are patients that have very forgiving and very unforgiving connective tissue. I liken it to some people are born with connective tissue that is much like a new rubber band. It stretches and goes back into position endlessly. And then at the other end of the spectrum, there's connective tissue that's like an old rubber band. It stretches and it either stays stretched out or it breaks. And we know this from studies done about 20 years ago where they actually examined the connective tissue from women that are going prolapse procedures and compared it to women having procedures that didn't have prolapse. And it'd be nice if we had that test, but we don't have that test available to us today. But it was certainly a groundbreaking research that educated us that not all connective tissue is the same. Smoking is certainly connected. I don't think the mechanism is 100% understood, but it is linked. Stopping smoking doesn't change prolapse, doesn't go away if you stop smoking. And then anything that injures the pelvic floor, motor vehicle accidents, surgeries where the pelvis is broken or an accident, vacuum deliveries, forceps deliveries can all damage the pelvic floor in some cases. And then the way hysterectomy is done can also damage the pelvic floor. And that has changed dramatically over time. We used to do a lot of things in the early 90s when I trained to help prevent pelvic prolapse at the time of a hysterectomy, for instance. And then we went through a phase where the thinking was that was not necessarily helpful and we shouldn't be doing it. And then we have a generation as a result of women that have increased prolapse. And now the pendulum is swinging back and we're doing more of these things that we used to do that we had abandoned. So many factors are involved here. So what are the symptoms of pelvic organ prolapse? They're varied. It's not to say some women have multiple complaints or symptoms. Some have only one. I had a patient that came in the office just this week, and the only thing she really said is, I've noticed that I just can't use a tampon. I can't put it in. It doesn't stay in. And that was the first thing I thought of is, prolapse. So she was kind of young, but it turned out that's what she had, but that was her only symptom. Certainly urinary and or fecal incontinence can be a symptom. Pain, pelvic pain with intercourse, pelvic pressure, a vaginal bulge, something coming through the vaginal opening that wasn't there previously. Sometimes bleeding. A cervix, for instance, can come in contact with clothing and it's not designed or built to withstand the rubbing on clothing, so it can bleed. So sometimes patients will present with bleeding. It's very often the patients will complain that they have difficulty starting the urine flow. takes them an inordinate amount of time to empty their bladder. Their urine flow is slow, or when their urine flow stops, they just don't feel like their bladder is completely empty. And then often a difficulty having bowel movements, although many times this is mistaken for constipation, and there's not a recognition initially that this is actually prolapse. So as pelvic organ prolapse, symptoms can worsen, symptoms can change. Bulging or pressure can worsen. It's not uncommon to have symptoms that worsen during the day. You can wake up in the morning and feel really pretty good. I like to say prolapse is fluid. You know, you can sleep and you're on your back, and pelvic organs tend to fall back in place, maybe not exactly back to the normal position, but as you are on your feet and active and increasing the pressure in your abdominal cavity can push on the pelvic floor and the pelvic organs, and prolapse worsens. Some patients will come in and say they feel like they're sitting on something, maybe a ball. People start noticing they have to put fingers in or around the vaginal canal to have a bowel movement or even to urinate. Again, even more difficult time starting urine flow or a very slow urine stream. I've had many patients come in and say, you know, I was at work and I was in the bathroom and I could hear other people emptying their bladder, and then I heard myself and I realized I had a problem, but it wasn't until then that I realized it. Sometimes these symptoms can become background noise that you don't really realize it until there's some sentinel event that you realize there's something that's very different about the way your body's working. Some patients will have urinary frequency, low back discomfort. Low back discomfort, we think, comes from a lot of the support for the pelvis goes to the back of the pelvis, and the support might be damaged, and but it's still there, it's still present, has nerves in it, and so a lot of it is essentially referred pain because of the origin of the support coming from the back or the side of the pelvis. And like I said earlier, needing to lift the bladder. Some patients, their bladder is protruding and they don't leak anymore. But they also have a very difficult urinating. They have to actually reduce the bladder, get it back into a closer position to normal just to empty, and many times pain with intercourse. So there's many types of pelvic prolapse, and this slide kind of represents that we've got some changing names. You know, on the right side in parentheses, we've got some of the old names: Cystocele, Rectocele, Vaginal prolapse, and some of the newer names reflect that. You know, when we see a bulge in the vaginal canal, we assume that the bladder is on the other side of it if it's the wall that's common with the bladder, but the truth is we're not really sure. So terminology is changing, so we now refer to an anterior vaginal wall prolapse, which is basically the same thing as a cystocele or a urethra. And I'm gonna show some pictures very shortly, so you'll really be able to see this. A posterior vaginal wall prolapse, the posterior wall of the vaginal canal is common with the rectum, and so the old name was rectocele and or enterocele. Enterocele references that sometimes small bowel will be in contact or pushing into the vaginal canal, and we'll see a picture of this as well. Apical support refers to the top of the vaginal vault in the case of a hysterectomy, or if you still have a uterus, the uterus can actually be prolapsing. So this is what we're talking about here is the top of the vaginal canal, and it really depends on whether you have a uterus or your uterus has been previously removed. And we see rectal prolapse, and rectal prolapse isn't really in the area practice for a urogynecologist, more of a colorectal surgical issue, but we diagnose it and then refer the patients out. Because many times patients will come to see us and we'll figure out that it's not actually a rectocele, it's a rectal prolapse, which is a very different problem. So here's a picture of normal anatomy. If you look in the very middle of the picture, you see the vaginal canal. Notice that the rectum is to the right and it's not there's a space between the vaginal canal and the rectum. And if you look to the left, you see the bladder and the urethra, and there's also space, and neither the rectum or the bladder is moving into the vaginal canal. And you look at the very top of the vaginal canal, you see the cervix, which is the portion at the very top of the vaginal canal, and then you see uterus. So this shows everything in a normal position. And if you look at the bladder, when the bladder needs to empty, it's basically a downhill process. The bladder contracts, there's a muscle that wraps around the urethra, and you get downhill emptying. And when the bladder drops into the vaginal canal, that really changes the function. It's difficult. The bladder wasn't meant to empty urine essentially uphill or through a kinked urethra, which is often what happens. So when the bladder changes positions, it can have a big impact on how the bladder works. And likewise, the rectum, when the rectum is bulging into the vaginal canal, it really alters how women have a bowel movement, and you'll see in a picture. So kind of keep this in the back of your mind, and as we look through some of these pictures that are coming up showing abnormalities, it'll be pretty obvious. The pictures are showing extreme examples to try to make the point. But you can if you start to think about it, you can see in these pictures that are coming up that anatomy has changed dramatically, and function definitely changes. It is also an interesting thing about urogynecology in that I'm always amazed that when we get body parts back into their more normal position, I always tell patients, we're never going to make your body like it was before you had a baby, but we can get things, body parts such as the vaginal canal, the bladder, the urethra supported and back in a more normal position. And it's amazing how much function returns when we do that. Sometimes that's the starting point. We get the anatomy as close as we can to normal. Then we deal with any residual problems in terms of urethral sphincter issues, maybe the nerves that operate the bladder. We'll talk more about that in the second half of the talk. Let's look now at an anterior vaginal wall prolapse or cystocele. In this case, you can see the bladder's really in an abnormal position. It's dropped into the vaginal canal. Now it's starting to drop through. So you can see in the lowest part of the bladder, it's bulging. Actually, patients become very aware of this when the bladder comes out this far. But what this picture isn't quite realistic. It makes it look like the urethra is completely straight. In real life, we see usually some kinking or bending of the urethra that makes it harder for the bladder to empty. But this is just trying to make you understand the difference of bladder position. So let's go on. So a rectocele, here you see the rectum is bulging into the vaginal canal and through. And it also makes it obvious, I think, that when stool is going to follow the path of least resistance. So as stool moves through the bowel, it's not going to necessarily go through into the rectum like in a normal position. It's going to go into the rectocele pouch, and that's why people discover if they push with fingers, they can redirect or reduce that prolapse and redirect stool. Sometimes people don't understand that relationship, and they're treating with not a diuretic, but a laxative, trying to break up the stool and turn it into liquid, and then they can evacuate it. But you can certainly see why this would make it hard to have a bowel movement, because stool is just not going to go in the right spot. And this shows a uterus that has moved through the vaginal canal and is now protruding. This could be very uncomfortable. Usually, you're going to see the bladder moving with the uterus, because the uterus is and the bladder is attached to the uterus in the lower segment. So you usually see the bladder and the uterus moving together. But again, this is for the sake of understanding what a prolapse uterus looks like. And so after hysterectomy, the vaginal canal can prolapse, and usually, and this is a good picture showing that the bladder usually moves with it. This is what I was talking about earlier when we changed how we were doing hysterectomies, and we didn't do things to support the top of the vaginal canal. Many women showed up 10 years after hysterectomy in this kind of condition. And again, this is an extreme example, but it can be uncomfortable. It can cause back pain. It can cause pressure, and have a big impact on how the bladder and potentially how the bowel works. So how do we diagnose pelvic organ prolapse? And typically, the most important component is a pelvic exam. So one thing that's different is when we use a speculum, I always tell patients will tend to push things back where they should be rather than where they really are. So I will start with a speculum exam, and then I take the speculum apart and only put one half in and have the patient bear down. And then we had, in many cases, get a pretty good idea what is moving, and to the extent it's moving into the vaginal canal. sometimes people have such severe prolapse, we don't even really need the speculum. And we might have to use it to figure out, are we looking at rectum? Are we looking at bladder? It can be difficult to tell. And so the speculum will help in that situation. In many cases, but not all, we don't need urodynamics or cystoscopy or ultrasound or MRI, but they can sometimes aid us in having a better understanding of how the prolapse is affecting function. So urodynamics is a test we do in the office. We basically take the bladder through an empty fill, empty cycle. We get a really good idea of what's working right, what's working wrong, and it can point us in the right direction in terms of is pelvic organ prolapse impacting the bladder, what bladder issues are present, and then we can come up with a treatment plan. Cystoscopy, we're using that to see from the inside. Sometimes I look in the vaginal canal and I can definitely tell that the bladder's out of position. Sometimes it's not until I do cystoscopy and the bladder has several hundred cc's that I get a better idea of the extent of the prolapse, and looking inside the bladder sometimes really helps to better understand the degree of prolapse and potentially how the prolapse is impacting function. And again, ultrasound we do quite often. CT or MRI are less frequently performed. So treatment. In many cases that are very, very mild, we might just do observation. Many times we'll use pelvic floor exercises or physical therapy trying to strengthen the pelvic floor muscles. So remember I said earlier the two major sources of support are the connective tissue and the muscles. Number one support we believe is connective tissue. So if connective tissue is torn, many times muscles can kind of take up the increased load and prevent some of the prolapse from occurring. But as muscles weaken, then the prolapse becomes much more obvious. But pelvic floor exercises in mild cases can strengthen the pelvic floor muscles. It won't make the physical therapy won't make severe prolapse go back into position. It won't heal the connective tissue, but it can strengthen the pelvic floor muscles and help to lessen some of the symptoms. If physical therapy and observation aren't working and patients need more help, then we're usually talking about a pessary and or surgical repair. I encourage a lot of patients to try a pessary. Now, some patients just decide that is not something that they want to try. They don't think that in their lifestyle that's going to be a good fit for them. But many patients try it. And the truth is, I always tell patients, we don't know how you're going to react to a pessary, how it's going to work for you. Pessaries are typically very good at supporting the bladder and the uterus. We sometimes struggle to give the urethra enough support. So sometimes we'll support we'll ironically support the bladder, but not the urethra, and actually worsen incontinence. But as I always tell patients, we don't know until we try. Surgical repair can be, usually we're doing multiple things. We're supporting the top of the vaginal canal, we're supporting the bladder, we're supporting the rectum, we're supporting the urethra, but we break it down into apical suspension, which is doing something to support the very top of the vaginal canal. And then we break it into supporting the anterior wall common with the bladder and the posterior wall common with the rectum. And I'm going to show some pictures of all these things. The focus today on surgical repair is being minimally invasive. The reason for that is it's faster recovery, reduced pain, reduced blood loss. And we really believe that when we get you back to normal function quickly, it really reduces some of the postoperative complications like blood clots in your legs or pneumonia. We just don't see that as much when we get you back to your normal function. Many people are walking the day of surgery if they're awake enough. So the way we accomplish minimally invasive surgery, my practice is heavily robotic. I believe that the robotic procedures I can perform have the best outcomes. Vaginal surgery is still very much a part of pelvic organ prolapse repair. One of the best procedures we have, which I'll show a picture of, is called sacrocolpopexy, and it has been a mainstay since about the 80s. The difference today is I trained doing that procedure through a large open incision from the belly button down to the pubic bone. Now we do it robotically and make 5 8 millimeter incisions, and people are going home the next day. Let's move on. So examples of pessaries. Certainly the pessary on the left, the ring pessary, is a much more common pessary. Sometimes there's like a little area that's enlarged on that ring that supports the urethra, additional support in that area. So pessaries are typically made of silicone. They're varying sizes and shapes, and this is just showing the two most common. We have rings, we have cubes, we've got quite a few different sizes. They fold and they go in the vaginal canal, and they do need to be removed at some point. You know, I've got patients that take them out every day, wash them with soap and water, put them back in the morning. We've got patients that come in every 3 months, and we take them out, clean them, and put them back. So there's a big variation in terms of the maintenance of the pessary. The pessary on the right is a less common pessary. I usually use a Gellhorn when a ring pessary doesn't work, and the reason for that is the Gellhorn can be difficult, if not impossible, for a patient to remove, and I even struggle in the office to remove it. So we try to go the easy route and go with a ring pessary. So a ring pessary is a non-surgical procedure. There is a maintenance aspect to the pessary. The only concern I have about pessaries is that I've had patients that we manage them with a pessary for decades, and then the pessary stops working because the prolapse worsens. A pessary won't stop the prolapse from necessarily progressing, and then I liken it to, we kick the can down the road, and now the patient's older, maybe more medical problems, and we can't find a pessary that works. That's one of the things I'm not too keen about with the pessary, but for many patients, it's a great option. So examples of vaginal repair, there's various ligaments in the pelvis. If you look on the left side, you see the uterosacral ligament. That's a ligament that naturally supports the cervix and the uterus, and we can utilize that ligament to attach to the vaginal canal to give it support. And this is showing an example after the patient's had a hysterectomy, and we're using the uterosacral ligament to support the vaginal canal. So this is an example of an apical support. It's not supporting the bladder or the rectum, but it is supporting the top of the vaginal canal. Uterosacral ligament is a very nice procedure. It is very anatomical. So what I mean by that is when we use the uterosacral ligament and we use that to support the vaginal canal, it keeps the vaginal canal on a normal axis, which can aid in function. On the right side, you see a sacrospinous ligament suspension, and you typically are going to see the vaginal vault deviate slightly from the left, either to the left or right. So you can use the sacrospinous ligament on the left or the right. You're not going to use both typically. And then the nice thing about both of these procedures is they can be done using a vaginal approach. The one other thing is again, these are apical. It sometimes doesn't address a bladder that's dropping. That's one of the issues we have with these two procedures. So you're still going to be doing something else to help the bladder and rectum, but this is going to help support the top of the vaginal canal. So this is an example of a sacrocolpopexy. We started doing sacrocolpopexies in the early 70s. By the early 80s, research had shown that was the longest lasting and most successful repair that we had. And what I like about it is it not only addresses the apex of the vaginal canal, but it also addresses the bladder and the rectum. It does not address the urethra. We have to address that separately, but there actually isn't a procedure that addresses all components, bladder, rectum, apex, and the urethra. So the procedure does utilize mesh, and that makes people a little bit anxious these days. A lot of people's takeaway is that mesh is bad based on commercials they saw. And I always tell patients, you can't use plaintiff attorney TV ads as your source of medical education. The truth is not all mesh is used the same way. There was a procedure that came out of Europe that was very well intentioned in the early 2000s. It was meant to give patients an option to keep their uterus. It was meant to give them a minimally invasive approach, and it was meant to be long lasting. And it was very novel use of mesh. I think I have a picture coming up, but it just didn't work. It particularly didn't work in diabetic smokers that were menopausal. We're not really sure why that is, but it was a little bit different. The sacrocolpopexy, we attach a graft to the front and the back of the vaginal canal to a ligament in the back of the pelvis. And in the case of the procedure that came out of Europe, the support goes laterally in the pelvis, and it's a bit of an awkward way to support things, and that's where a lot of the problem resulted. The European procedure is no longer in the market in the U.S. I don't know if it ever will be. But it's created a lot of dialogue, which is actually a good thing, a lot of dialogue about mesh. The one thing you can say about sacrocolpopexy is it's been out now for 48 years, going on 49 years. It has stood the test of time. It's the most successful repair we have. And today we do it robotically. I was trained to do this procedure as an open procedure as a resident, and it's quite I hate to use the word game changer or the phrase game changer, but it really does make a difference. I did one of these procedures yesterday on a patient, first thing in the morning on Tuesday, and she was going home by 1 o'clock. And I had told her when I rounded on her this morning, we'll see how you do today. You know, you don't, it's hard to know first thing in the morning, you just woke up. Let's see how your bladder works today. If you don't feel up to going home tonight, you know, we'll keep you until tomorrow. And I got a text from her nurse saying, you know, at 1 o'clock saying she's emptying her bladder. She feels great. She wants to go home. And so she went home. And that happens more often than not. Patients, the most common comment I get from a patient is, I feel really pretty good. I'm surprised at how good I feel. What do I have to do to go home? So it's become kind of a mainstay, and I would say it's probably consensus this is the most successful procedure we have. And this is a picture of the procedure that we don't use any longer. And mesh was put in the vaginal wall in the areas that you see blue, and the mesh came out, the supports came out lateral, and it's really, I think that's was what caused the problem. The mesh was in the wall, it was very heavy, and the supports were lateral, and the physics of the procedure just simply didn't work very well. So this is an example of a procedure that created a lot of anxiety and a lot of concern among patients. Even patients having general surgery procedures to fix hernias are concerned about a mesh as a result of this particular procedure, which again is no longer on the market in the United States. And you know, I debated whether to talk about this particular slide today because sometimes it gets confusing. You know, what's the difference between vaginal mesh and sacrocolpopexy? And there's actually quite a big difference in terms of how the two procedures worked. And again, this procedure had a shelf life of about 5 or 6 years, and we realized that there were some problems. And one of the biggest problems is the FDA did not require testing of this procedure like it should have when it came from Europe to the U.S. The sacrocolpopexy has stood the test of time. It's going to be out for 49 years sometime next year. So a big difference. So let's switch gears now and talk about bladder dysfunction. Like bladder dysfunction is very common. It affects 30 to 50% of women. Certainly rates of leakage go up with age, but we do see a lot of young women who have leakage. And I think probably the message, if anything, is it's not normal, and it's not normal at any age. So why again, just like prolapse, patients will ask me, well, why do I have this? Why did this happen? Many of the same things that cause prolapse also cause bladder dysfunction and incontinence. Certainly pregnancy, vaginal delivery, surgeries, aging, again, the same thing, connective tissue aging. So we know that when there's a vaginal delivery, that connective tissue and muscles can be damaged, and that can lead to, first of all, lack of support for the urethra, and then secondly, the bladder. And again, genetics, you know, as we talked about earlier, not all connective tissue is the same. Menopause, we know that lack of estrogen can have a big impact on how the bladder and urethra function. And we previously, for several decades, did not think that adding back estrogen, whether it was a vaginal estrogen cream or hormone replacement therapy, improved bladder function. But there's new interest in this area in the last 5 years. And for mild symptoms, sometimes vaginal estrogen cream, which is not the same thing as hormone replacement therapy. We're still not big proponents for hormone replacement therapy, but that's a whole nother lecture. Diuretics can exacerbate underlying problems, and diuretics don't cause bladder dysfunction, but they can just put the bladder into high gear and exacerbate problems. So what are the different types of urinary leakage? One of the big ones is stress incontinence. It's the loss of urine that occurs at the same time as anything that increases the abdominal pressure, such as sneezing, coughing, laughing, exercising. Sometimes something as simple as standing up or even walking can cause stress incontinence. Urgency incontinence is one moment you're fine, and the next moment you have a very sudden urge to urinate, and before you can make it to the restroom, 1 or 2 steps into that trip, you're leaking. It could be a small leak or a large leak. So urgency incontinence is part of something called overactive bladder, and we'll talk more about that in the next slide. Another feature is urinary frequency, which is urinating more than 7. Some people use 8 times a day as normal. Getting up 2 or more times at night is something we think of as abnormal, particularly when you have a hard time getting back to sleep. I've had patients coming in, so we think of 7 to 8 times a day and 0 to 1 at night is normal. And I've had patients coming in when we do a bladder diary, and they're going every 20 minutes, every hour. So they're urinating greatly in excess of 20 times a day, and they're simply exhausted by it. We do see mixed urinary incontinence. It's a common, patients have a little bit of stress and they have a little bit of urgency, and usually the focus is on treating the aspect that bothers the patient the most. You know, there's an emerging concept that maybe everybody has. There's a spectrum, and on one end is stress and one is urgency or overactive bladder, and everybody's got a little bit of it, of both, and it's just what's the dominant. And because we previously thought of it as very discrete problems, but we now are starting to think that there's more linkage between the two than we previously have thought. So again, an emerging concept. So overactive bladder. Overactive bladder is a really quite complex condition. We can reduce it to really simple terms like frequency and urgency and getting up at night. But then you talk to a patient who can tell you a story about how they were out for 5 or 6 hours and they were running errands and grocery shopping or doing whatever they had to do. And then they came home and they put the key in the lock of their door, and then suddenly they had a very sudden urge to go. And they're really kind of perplexed by this because sometimes they make it to the bathroom and sometimes they don't. But it's how was it they were spent the last 4 or 5 hours without a single bladder problem, and then when they get home and they hear the key in the lock, you know, there's some trigger that puts the bladder into high gear. And essentially, if you think about what happens when the bladder empties, you know, you go to the bathroom or a restroom and you create a situation where you're comfortable, you get your clothes out of the way, and then you send a subconscious message that it's time that the bladder can empty, and then the autonomic nervous system takes over, and that's the part of the nervous system that controls things like our heart rate, our respiratory rate, passage of food through the GI tract, things that we just don't think about. So the autonomic nervous system takes over, makes the bladder wall muscle contract, and makes the muscle that wraps around the urethra and acts as a valve relax. And overactive bladder is very simply, as the bladder fills, the bladder doesn't like being full, and it sends messages through sensory nerves, and the system that empties the bladder starts operating when it's not supposed to. So you have an urgent sense to go because the bladder is contracting, and it's happening more than once a day because your bladder is filling all day long. So it's this very complex, very complex syndrome, if you will. And you know, sometimes it's only a problem at night. Sometimes it's only a problem during the day. Sometimes, like I was saying, the key in the lock. There's triggers that patients have, but it can definitely have an impact on patients. You know, it doesn't take many times to have an accident when you're out and about, and you can start, especially when patients are having small leaks, it's not such a big problem. But when they start having big leaks, then it becomes much more problematic, and patients start to think twice about doing things, and then in many cases, I've had patients come in and they're so worried they're going to have an accident because they've had some accidents and they've been embarrassed that it starts to limit activities, and they become actually homebound. It can have a very serious impact on their quality of life. So I always educate patients. OAB is very treatable. You know, we have things we can do, and I just encourage them to seek treatment, and we can many times make a very big impact on the quality of life and get them back out doing things that they want to be doing. So diagnosis of overactive bladder and urgency incontinence. And urgency incontinence is kind of think of it, OAB is in one circle and urgency incontinence is another circle, and the two overlap. So urgency incontinence, I think of as a more severe form of overactive bladder. But how do we diagnose it? Certainly history can give us some clues. If a patient tells you they have urgency, they don't leak with a cough or sneeze, they go to the bathroom a lot, the picture starts developing that it looks like overactive bladder. We can do a physical exam, and if we see that there isn't any prolapse, then OAB is bubbling a little closer to the top of the list. We always do a urine sample, and we're looking for chronic infection or a bladder infection. It's very helpful. We don't always do bladder diary, urodynamic test, or cystoscopy on every patient. Many times we'll start a simple therapy without doing any of the fancy tests. But if we aren't making progress with some of the more simple treatments, then we move on to things like a bladder diary, urodynamic test, and cystoscopy. And so bladder diary just helps. A patient literally records how often they go to the bathroom and if they leak and did they have urgency for a 24-hour period of time. And sometimes when we try to remember or guess how often we go or how often we leak, we sometimes either overestimate or underestimate. But bladder diary really helps put a face on the nature of the problem, because I've had patients that say, yeah, I go a lot. I'm not really sure how often I go. And then they bring a bladder diary in and they've gone 24 times in a one day, in a 24-hour period. Again, urodynamic testing, we take the bladder through an empty fill, empty cycle, and really helps me understand what's working right, what's working wrong, and points us in a direction for treatment. Cystoscopy can rule out other conditions that mimic OAB, and again, helps me understand, in many cases, how the bladder, I get additional information on what the bladder is doing and doing wrong. So treatment. Certainly pelvic floor exercises are a mainstay of treatment. Pelvic floor exercises came out, we used to call them Kegel exercises, came out in the early 90s, and they were really meant to treat stress incontinence. Again, remember I said earlier, pelvic floor exercises are strengthen the muscles in the pelvic floor, and the thinking was if we improve the support for the bladder and urethra, we'd reduce leakage and maybe prevent surgeries. It didn't quite work out that way, but along the way, women that had mixed incontinence found that their overactive bladder symptoms improved, where their stress incontinence did not. And that was a bit of a surprise. I won't say that we really understand why pelvic floor exercises are helpful with OAB. It may be that when the exercises are done on a regular basis, that somehow alters that abnormal triggering of the bladder emptying mechanism. But the truth is we just don't know, but we know they work. Bladder irritants, such as caffeine, alcohol, citric acid containing foods, and hot spicy foods can irritate the bladder. It's not to say all those irritate the bladder, but for individuals, we might find a trigger, and then when they limit that trigger, they have dramatic improvement. Medication, when you've exhausted pelvic floor exercises, avoiding irritants, and bladder retraining is when sometimes we find patients that have just by habit gone to the bathroom more frequently, and when we ask them to do bladder timed voidings, basically figuring out how long they typically go between emptying their bladder, say that's 15 minutes, and then we ask them for the next 2 days to add 5 minutes to that. So they just literally time it, and they force themselves to wait that extra 5 minutes, and then when they hit 20 minutes and they're able to do that, then we add another 5 minutes. I've had patients go from 20 minutes to 2 or 3 hours in 2 weeks with that. But it would be nice if that worked for every patient, but for some patients, that's just not an option. But usually our testing will help us figure out if that's an option. Medication has been a mainstay for treating overactive bladder up until recently. Many times we find that particular medication that controlled symptoms that didn't have side effects, and that's what we would use to treat for, and sometimes for decades. There's been some concern that medications might have some other long-term effects on maybe putting you at higher risk for Alzheimer or dementia. It's not to say that everybody that takes medication for overactive bladder will have dementia or Alzheimer's, but there's concern. And the thing that muddies the water and makes it difficult to know is that if we look back over the last 2-3 decades, the dominant therapy for overactive bladder has been medication. So the question becomes, is the problem overactive bladder, which is essentially a nerve disorder, or is it medication, or is it a little bit of both? And as I always explain to patients, we can't make overactive bladder go away easily, but we can change the treatment. So treatment protocols have been changing. We've been going to bladder injections of Botox, for instance, or nerve stimulation. Nerve stimulation has been around for about 20 years. Botox has been around for something short, just short of 10 years in the United States. Has been out longer in Europe. Both have advantages. If a patient asks me what I think is better, I go more for nerve stimulation. I think it's, we do basically a test phase and then we do a procedure and it's outpatient, and then that can last for years, 15 years in some cases. And I think that's easier than bladder injections that we're doing 2, 3, or 4 times a year. But ultimately, a patient decides. I educate the patient about the options, on the pros, the cons, and they ultimately decide what it is they're going to do, if anything. So let's move on to the other major type of stress urinary incontinence, or urinary incontinence, which is stress urinary incontinence. And that's basically a loss of urine that occurs during some activity that increases abdominal pressure, such as sneezing, or coughing, or laughing, or exercising, or standing up, or walking. It's very, very common. And again, just like overactive bladder, the severity and frequency can change. Many times it's patients follow a course where they leak occasionally. They leak maybe once a month or once every other month. And at that point, they're typically not coming into a doctor. They may be disconcerting, but people aren't usually rushing in to seek treatment at that point. But when the severity increases and the frequency increases, and you're leaking 3 or 4 times a day, and you're bringing a change of clothes to work, for instance, then most people are going to seek treatment. Usually there's some event that occurs that triggers patients to now seek treatment. I've had patients tell all kinds of stories. I had one patient that she was shopping and she was checking out and buying something at a department store, and she had a sudden leak. And she said the thing that saved me was the clerk gave me 2 big bags. I put one in front and one in back. And I got out of the store and I went home and I made an appointment to see my doctor. So sometimes there's some event like that just it's the straw that broke the camel's back, and the patients seek treatment. Again, just like overactive bladder, sometimes stress incontinence can become so severe that people start to limit their activities, and then you start to see a serious impact on the quality of life. And so I always try to make patients understand that stress incontinence, again, is very treatable. And our goal is to treat and then get patients back to their normal activities so they can enjoy things they like doing in their life. So basically, this is the same slide as overactive bladder. How do we diagnose it? We do a history, we do a physical exam, we do a urine culture. In some cases, we stop right here and we say, if it's more mild symptoms, we might talk about pelvic floor exercises for a couple months, either at home based program or a referral to a physical therapy unit. And then if the patient comes back and they're not quite where they want to be, then we move on to more testing. Again, the bladder diary for 24 hours, urogenic test where we take the bladder through an empty cycle, and looking in the bladder to get a better idea of what's going on. So sometimes the diagnosis is tailored to the severity of symptoms, is what I'm saying. So how do we treat? Again, pelvic floor exercises. Sometimes that will get people where they need to go, or lessen symptoms to the point where patients find their leakage acceptable. Weight loss has been associated with decreasing or elimination of stress incontinence, but as we all know, that can be it can be very tough to lose weight for some patients. We do a lot of work with our bariatric center at St. Mary's, and we see this all the time. Sometimes it's a delicate conversation, but sometimes it's important to educate the patient that if they were to lose weight, this could have a very beneficial effect on their stress urinary incontinence. Again, avoiding irritants can help with stress incontinence. And then again, treatment is centered around pessary or surgery. So what treatments do we have available to us? Today, the 2 surgical treatments we have are either a bladder sling or urethra bulking. Both have been around for a long time. If we look at sheer numbers, what's the most successful? And actually, there was a study that came out a couple of years ago that looked at urethral bulking against bladder slings, and bladder slings came in around 93-94% effective, where urethral bulking was about 87% successful. So a bladder sling is done outpatient. There are some options to do it. Some doctors will do it actually in their office. I do not do this. I think it's a little easier to do it in the operating room, and even if we do it under local sedation for some patients that can't have a general anesthetic. One of the benefits of bladder slings is they have very high success rates. There's probably closing in on 300 studies on a bladder sling and how successful they are. And many times patients will come in and say, I got a sling that's just not working. And when I question them, two things have happened that can damage a bladder sling. One is you didn't have prolapse when the bladder sling was placed, and now you've developed significant prolapse, and it's damaged the sling, and it just doesn't work the same way. Or sometimes the sling is still working. You're not leaking with cough, sneeze, laugh, or lip, but you've developed overactive bladder. But sometimes patients don't distinguish between the two. And so my job is to educate patients about what's going on with their sling and whether it's working or whether it's not working. But many times it's still working. I've seen many patients that have had a sling and they're 20 years out plus, and they do not leak anymore. And the common denominators, the nerves that operate the bladder, are working great, and their pelvis is stable. Urethral bulking is undergoing a bit of a resurgence right now. We've had it for a long time, but it was something that we did only when everything else didn't work, and it required multiple treatments, sometimes several a year. There were some technical difficulties that made it, in certain patients, difficult to bulk them, and I'll show some pictures of both these. Today, we have some newer products that have much higher success rates, last many years, 6 or 7 years as opposed to 6 or 7 months. One of the beauties or nice things, beautiful things about urethral bulking is it does not require incision, and again, we can do it in the office. So let's look at some pictures. So this is a very classic picture of probably the most common sling that's done. It's a transobturator sling. Incision is made about 1/2 inch in the vaginal canal underneath the urethra, and then on the perineum, 1/8 of an inch incisions are made and then the mesh is trimmed. Definitely the most successful treatment we have for stress incontinence. There are some other versions. There's mini slings where you make 1 incision, and there's versions that go up to the abdominal wall rather than coming out of the perineum. But definitely the transobturator sling is the most common and most successful sling we have, and it's been very well studied. So urethral bulking is, if you look at the picture on the left, you see the bladder and you see the urethra and you see the little blue circles. Basically, a water-based colloid is injected into the area you see in blue, and it's done with a cystoscope. And we numb the urethra with lidocaine gel, and we usually give some other things so patients are relaxed, and we do this right in the office. I've done this many, many times in the office, and patients are very comfortable. I had not been bulking for several years because I was not happy with some of the bulking agents we have, but there's a new agent that's come out of Europe that's been out there. It's been out for many, many years, and we all asked at our meetings, well, why don't we have this? And the short answer was the company was based out of the Netherlands, and they simply did not want to deal with the FDA in the United States, and so they just did not even attempt to bring it to the U.S. because it's got quite a track record now. It's been used extensively in Europe, and now we finally have it available to us. And so it gives us another option for patients, a non-mesh option that works almost as well. I think it's going to revitalize bulking as a treatment option in the U.S. And so it's something that might be of interest to some patients, especially if the bladder itself is stable. And this might be a nice option for some patients. So that is the end of my talk. Again, the goal of all this is to basically educate patients, number one, about prolapse and about bladder dysfunction, diagnosing and providing treatments that patients find acceptable, getting patients back to normal activities in as minimally invasive way as we can is really what our goal is. So let's look. We've got some questions. I'm going to open this up. I think I'll be able to see them. Okay, I had bladder prolapse surgery in May 2020. The surgery was not successful and the bladder has prolapsed again. Should I consider surgery again? You know, it would really depend on what procedure you had. That's a very, very quick failure rate. I'm not sure what procedure you had, but I want to guess that you probably had a suture repair, but I don't know that for a fact. I definitely, if I would encourage you to be evaluated and see if there's something else that can be done. The question number 2 is, how do you know which one is dropping into the vaginal canal, the rectum or the bladder? Again, physical exam, we can usually see that pretty easy. Sometimes when we look if we haven't used a speculum, we just look at the perineum, we see the labia and we see the vaginal opening and we see a bulge. We see something that shouldn't be there. And we really aren't sure if it's the rectum or the bladder. And by simply putting part of a speculum in, we put a speculum in and just gently retract towards the rectum, and then we'll quickly see, is this the bladder? Is this the cervix, or is this the rectum? So the short answer is, by physical exam, we can typically always tell you what is actually prolapsing. What is a pessary? So a pessary is a silicone ring, is the most common shape, but it could be a cube, it could be a donut. It's a object that comes in varying shapes and sizes that is placed in the vaginal canal, attempting to support the uterus, if it's still there, the vaginal canal, the bladder, the rectum, and ideally the urethra. What does a pessary look and feel like? Where does it sit? Do you remove it and then put it back? A pessary is, again, the most common shape is a ring. Kind of like, if you're familiar with diaphragms, it's like a heavy-duty diaphragm. Most of the time when we put a pessary in and it's the right size, patients, like I put one in this morning in a patient, and she is contemplating surgery, but she wanted to try. This is not a good time for her. She doesn't want to have surgery, won't even consider surgery until maybe the second quarter of 2022. And so in the meantime, she wanted to try a pessary. And she was really very pleased today because we put a pessary in the vaginal canal and she didn't even feel it was there. It was giving her some support. We stepped out of the room and she took it out and put it back in. We instructed her how to do it and made sure she was able to do it. She wanted privacy, so she was able to do that, and she left, and she'll come back and see us if she needs. And like I told her, you know, if you have any signs of infection or you have signs of vaginal infection or discharge, you know, you need to come back, and then also come back if you're not happy with the support it's giving you. So it does basically occupy space in the vaginal canal. You just put it in and push it to the back of the vaginal canal, and it just assumes a pretty consistent position from time to time. If you take it out and put it back in and push it all the way back, it just assumes the normal, a very typical position. Is a pessary trail like a sling? No. Well, you know, yes and no. So a pessary sometimes is very frustrating to, it's meant to support the urethra, but sometimes we just can't find a pessary, truthfully. We can always tailor a sling to anybody's anatomy, but we sometimes struggle with a pessary. And I'm not sure, this might be a typo. So is a pessary trail like a sling? I'm not quite sure what that means, but maybe that's a pessary trial. So a pessary trial is where you come into the office and we try a pessary, and some patients will put it in and they'll say, nope, that is definitely not something I'm going to do. Other patients will try it for a few days or a few weeks or even a few months. And a sling is a surgical procedure. So they try to accomplish the same thing in some situations, but they're very different procedures. Can a pessary device be used if you have an ID? Yes. Short answer is yes, you can. My GYN has told me on several occasions not to let any surgeon perform surgery with mesh due to severe complications. Well, I would disagree with that, doctor. Some of that is dated information. Unfortunately, many OB-GYNs are not trained in sacrocolpopexy. And I think, again, one of the problems we had with the procedure that came out of Europe is some doctors they were only doing 1 or 2 procedures a year. The procedure had issues, and it's left many people, doctors included, with the idea that there's severe complications. And anything in life is risk versus benefit. And I think if you do a lot of sacrocolpopexies, I've done over 700 at this point robotically, and I believe it's a great procedure. It definitely works, and it can help a lot of people. But I'm very careful to counsel patients on what the complications are. I'm trying to keep up here. I'm getting a lot of questions, and yeah, okay, here we go. Is that an older surgery that's not done anymore? Not all mesh procedures, to answer that question, not all mesh procedures are the same. There are some, as I was saying, there are some mesh procedures that are no longer on the market. And there are some procedures that have stood the test of time and they've been out for over 45 years, going on 50 years. And so you got to be talking about the right procedure, I guess is what I would say to that. I'm hoping that this is the case, as I would be extremely anxious to have that done, and that's why I put out procedures. Well, it's unfortunate. I think your doctor is not maybe giving you the best advice. And if you look at the actual science out there, not all mesh procedures are the same is the only thing I can say. And there's some that you definitely want to avoid, and there's some that are very good. And so I wouldn't say that mesh is a big problem. I see this was put in earlier. Okay. I've read that some OAB meds can have impact on memory and cognitive function. Is this outdated information on prior drugs, and have they improved the medications? Unfortunately, all the medications we think, if used long-term, can potentially have an impact on memory and cognitive function. And that's one reason why many of us are limiting the amount of time you can be on the medications. I personally don't want patients on it for much more than a year. I've talked to some doctors that will go 3 years, but they're with every refill, they're again warning you about these potential problems. It's not to say that everybody that goes on a medication is going to have a problem, but we worry that it's increasing your risk. And when there's other treatment options that we don't think have risk, we're moving towards those treatments. So medications, I think, are all medications basically have these issues, and many of us are trying to avoid them. My 90-year-old mother has pelvic prolapse bladder. She has a pessary but can't remove it and clean it on her own, and has frequent UTI. She complains of discomfort every time she sees the doctor to have it removed and cleaned. And at our age, we are leery of surgery, but I'm wondering if she would be a good candidate for the surgery. 90-year-olds have more post-op problems, maybe the best way to say it. And she has a very legitimate complaint. Many of my patients have used a pessary, and they distinctly do not like having their pessary removed and cleaned, but it's something that just needs to be done. The oldest patient I've done surgery on is 91, and she was absolutely miserable. Her pessary stopped working. We couldn't find anything that worked. And so finally at age 90, she was actually 91, we did surgery, but it's not something we want to do. Part of it too depends on how healthy the patient is. So I would encourage her to seek evaluation. Does surgery to repair pelvic floor disorders also relieve bladder urgency? Well, if bladder urgency is being caused, it can, but it doesn't always. If bladder urgency is being caused by pressure from the uterus on the bladder, it will get better. If the urgency is being caused by nerve dysfunction, it may not get better. It may need some additional treatment. But typically what I find is that with bladder urgency, if you've got severe pelvic floor disorder, a lot of the treatments for urgency don't work very well until we get the pelvic floor supported. I thank you for your frankness and honesty, and we'll be making an appointment to get your opinion on my situation. That's wonderful. I welcome your welcome you coming into my office. Can rectocele cause urgency incontinence? Urgency incontinence we think of more of as a nerve disorder. So would correcting the rectocele correct the incontinence? Probably not. But if constipation goes hand in hand with rectocele sometimes, so if there's constipation that's part of the equation, that could be part of the urgency incontinence, because a dilated rectum full of stool can definitely impact bladder function. So not typically, but it's possible in that case. I have had consistent kidney stones. Can they sit in or accumulate in the bladder? If yes, are they noticeable or very visible? Typically, no. By the time a stone gets to the bladder, most people are urinating it out. We do see some patients with little stones that just produce an inordinate amount of little stones that stay in the bladder. But it's not typical that we look inside a bladder and see a stone. Usually when the stone gets to the bladder, it passes out with the urine. For women, should you see a urologist or a gynecologist, depending on the symptoms? Well, that's a good question. Some urologists are trained in treatment of pelvic prolapse, and some are not, and some just don't even seem to pick up on it. So, and of course, I have a bias being a urogynecologist. So it depends on the urologist, and it depends on their training, is a short answer. Where a urogynecologist can be able to deal with lower bladder dysfunction and prolapse for sure. You may or may not find your urologist is trained in all aspects. Is a bladder suspension the same as a bladder sling? Not necessarily. So bladder suspension is kind of a wastebasket term, and it could be that the bladder suspension was meant to support the bladder, or it was meant to support the urethra. So it's not specific. So a bladder sling specifically supports the urethra and is meant for incontinence, where a bladder suspension might be a bladder sling. Some people might refer to a sling as a suspension, or it might have been that the bladder was dropping into the vaginal canal and the suspension was meant to correct that piece of it. So a bladder suspension is not a very specific term. We don't like to use it very much. And if I said it during this talk, shame on me. What treatment do you suggest for someone who had a surgery to correct a prolapse uterus and bladder suspension is now experiencing urgency incontinence? Well, that might not have been related. I would encourage that person to be examined and to make sure that everything is currently in place, and then go down the pathway of avoiding bladder irritants, pelvic floor exercises, potentially medication, and then in severe cases, considering either Botox or a nerve stimulator. But I definitely think you should be treated for that. What is the cost of a sling and recovery time? Oh, that's a good question. If you do the sling, usually when a patient has this type of a question, we refer them to patient finance at the hospital. And it depends, it's going to vary based on how much your insurance covers. And so there isn't a set number for that one. Patient finance would have to help you, would give you codes and talk. If you do a bladder sling alone, usually most people, I usually tell them to take it easy for a week. You don't want to put anything in the vaginal canal for at least a couple weeks. So recovery time for a sling alone is really pretty fast, because it's a very minimally invasive procedure. Do treatments for prolapse affect sexual function? Most of the time, they improve sexual function, but it's going to depend on the patient. Many patients with prolapse don't have any structure in their pelvis, and when we treat prolapse, we're adding structure back in the pelvis. So sometimes position then becomes crucial again, and so patients have to be educated that if we're going to do, say, a pelvic prolapse surgery, for instance, there's going to be more structure in their pelvis, and that may impact function. But with education, it's usually not a big deal. One of the treatments for prolapse is a pessary, and usually pessaries and sexual function don't go hand in hand. You have to take the pessary out when you're sexually active. So a hysterectomy at 44, birth procedure done for stress incontinence, which caused urgent incontinence. need to change the angle of the urethra. And yeah, unfortunately, some of the old procedures, can definitely, that's why we use the sling. I would show you the transobturator sling. It's more of a hammock approach to supporting the sling than a birch is more like if you look at the angles, it's more like a U. And any procedure that supports like a birch, or we call it a retropubic sling, has the risk of causing urge incontinence. Yeah, that can be tough. Sometimes you need to be evaluated, and you wouldn't know what to do in this case until you did some probably repeating urodynamic testing, as well as a cystoscopy, and trying some treatments for urge incontinence before you really know which way you're going to go with this. But it can be a complex thing, and sometimes a sling needs to be revised. Would you recommend getting 2 doctor evaluations? I guess it depends on how comfortable you are with your doctor. I don't have any problems. If patients want to get a second opinion, I have absolutely no problem with that. Many times, if you're going to doctors that are good at what they're doing, I believe you should be getting pretty similar advice. But I have no problem. Sometimes a patient, you got to do what you're most comfortable with. And if you think getting a couple opinions is valuable, then by all means do it. Can incontinence cause chronic bladder infections? Yes. We think that in some cases I should say incontinence. A prolapse can cause chronic bladder infections, but if you're leaking, no. So I guess I reread that. I read that a little too fast. So can incontinence cause chronic bladder infections? No. Menopause can cause it. A bladder that doesn't empty efficiently can cause it, but not incontinence per se in my mind. Please share what exercises I can do and what not to do. So pelvic floor exercises are the exercises that I would recommend. It's meant to strengthen the pelvic floor, which goes from the pubic bone to the tailbone, and the urethra, the vaginal canal, and vaginal opening traverse it. If you go to the website Voices for Pelvic Floor Disorder, they have a very nice handout that's free under pelvic floor exercises. Or if you just go online and search pelvic floor exercises, you can probably find a multitude of instructions, or you can be referred to a physical therapy unit for that. Does bladder prolapse surgery involve a hysterectomy? Depends on what procedure you do. If you do a sacral colpopexy, what's been found over time is that the procedure works best and lasts longer and has fewer issues if the uterus is removed. So it depends on what type of bladder prolapse surgery and the severity. Some people will choose some of the older non-mesh repairs, and then you don't have to do a hysterectomy. If we're really talking about a sling, you don't necessarily have to do a hysterectomy. So it depends on the issue again. What are your thoughts on a sacrospinous ligament suspension for vaginal ball prolapse? I think it's a very good procedure. It's not my favorite procedure. So a sacrospinous ligament suspension will address the top of the vaginal canal, but it doesn't address the bladder. It doesn't address the rectum. So sometimes a sacrospinous ligament is done with other repairs at the same time. It's not. I think that a uterosacral ligament suspension is actually better, and I think a sacral colpopexy is even better than that. So. But it's a good procedure, but I would just say there are better procedures. Already had a hysterectomy. It depends on how. So to answer that question, you're going to have to know what else is happening in the pelvis. What are the symptoms are you having? Usually, a sacrospinous ligament suspension by itself isn't going to solve most people's problems, but you need to be evaluated to figure out if that's the case. Does age make a difference? Certainly, it depends on the nature of the problem. If a patient is younger and still wants to have babies, certainly I'm not going to recommend a sling. I'm going to say urethra bulking or a pessary is the way to go. If patients, robotic surgery opens the door for treatment that so we go back to the 90s, a big open procedure would not be something that we would do in an 80-year-old, for instance. And a healthy 80-year-old, in the last 2 months, I've had 2 80-year-olds that were adamant about not using a pessary after trying it. And we got opinions from their medical doctors, and in some cases their cardiologists, and they both had successful surgery. So it depends on the patient and other comorbidities and other medical problems they have is the bottom line. What can be done for damage for the urethra following childbirth is the question. And it depends on what I guess I would need to know what symptoms you're having. If you're leaking, then again, we're going to go down that stress urine incontinence pathway. So it would depend on what the damage is and what symptoms you're having. Describe nerve stimulation for the pelvic floor. So nerve stimulation is meant to treat overactive bladder. And so we do a test where let me back up one step. So with overactive bladder, the sensory nerves that are sending signals to the nervous system exit the back of the tailbone, the back of the pelvis. The nerves that operate the bladder travel in a different area. They travel through deep in the pelvis, not through the tailbone. So we have the luxury of stimulating the nerves exiting the tailbone and filtering out some of the error messages that cause urgency and frequency. So we basically do a test in the office where we numb up 2 spots, put little leads under the skin, and we tape it all down, and the patient wears that for 2 or 3 days. And we add stimulation. And the way we do the stimulation is we go up very slowly till the patient just starts to feel it, and then we back it down just so they don't feel it, and then they try it. It's basically a trial period for 2, 3, 4 days, and then we see if we're getting where we need to go. And then there would be a procedure, outpatient procedure, with about a 1-inch incision and a 1/8 of an inch incision that are made to place the nerve stimulator in the upper buttock, and everything is under the skin and it's rechargeable. So that's it in a nutshell. If you went to if you looked under sacral nerve stimulation online, you're going to find a couple different companies. There's a company that starts with the letter A that I use, so you can look at that and get more information. I had a stress bladder and had sling surgery 7 years ago and was successful. Instead of using a mesh sling, the doctor used skin from my lower abdomen. You did not mention this in your slide. Is something you do not recommend. We know that's a fascial sling. Not many people offer that sling. And I don't know that it's a good procedure. Some people think of it as a great procedure. It's an option. It's not something that I was trained to do, and most urologists haven't been trained to do it in my experience. So it's something that was done before mesh was available. Can you speak to the side effects beneficial to the bladder from vaginal rejuvenation laser? I don't know that we really know that at this point. Vaginal rejuvenation laser we think of as, it's kind of a controversial area right now. The professional organizations are not necessarily enthusiastic about it. Everybody agrees that if a patient has breast cancer and they have vaginal dryness and they're menopausal and they can't take vaginal estrogen, it might be a very good option. So we think of it more in that regard, and I don't know that there's much data out there on whether it benefits the bladder or not. It's not to say that somebody couldn't have that and then have some benefit, but I don't think that's the number one reason why lasers are used. Can a cervix prolapse? Definitely. So if you have a supracervical hysterectomy, so the uterus is removed, the cervix remains, the cervix can prolapse. And remember, the cervix is the part of the uterus that's in the vaginal canal. So the whole uterus can basically fall into the vaginal canal and out through the vaginal opening, and the first thing you're usually going to see is the cervix. So yes, it can. What causes frequent UTIs? Very complex question. Some of it we don't know. Basically, we think it's more common in menopause. We think that menopausal changes make it easier for bacteria to adhere to the urethra and the bladder wall. Sometimes bladders that don't empty frequently. And there's probably some factors that we just don't understand. We have some treatments like acidifying the urine with cranberry extract or D-mannose, makes it harder for bacteria to adhere, or even vaginal estrogen cream, but the exact mechanisms, we're not really sure. There's a lot of research going on in this area, and I suspect in the next 5 or 10 years, we'll know a lot more, but because we're learning a lot of new stuff in the last 5 years. Is it normal to have blood in your sample? I was tested today for stress incontinence. So the most common reason to have blood in your urine is infection. But we do see a lot of people out there, if you think about what the kidney does, it filters the blood of impurities and waste products. So many times blood in your urine in the absence of infection will trigger a workup to make sure that the kidneys, the ureters, the bladder, and the urethra are normal. And we do see people that have what we call benign microscopic hematuria, which means they have blood in their urine, but it's of no consequence, and it's just the way their kidney is operating. Discuss activities to avoid years after prolapse procedures. Well, I'm not a big fan of telling patients they can't do certain things after a prolapse procedure. I usually say repetitive heavy lifting is not a great idea. I like to joke and say it's time to sell your truck if it says 2 men in a truck on the side. Those types of heavy repetitive lifting are just not something you should do. But I'm a big proponent of saying get back to your active life. And I have patients that have procedures and they're weightlifters, and we have a conversation saying that to make sure they understand that might increase their recurrence rate, but I'm not going to tell them they can't do these things. So in general, I'm not a big fan of saying you can't do this or that. By nerve stimulation, do PTNS. So percutaneous tibial nerve stimulation is one option. And we offer it in our office. We don't get many takers. And the reason is you come in weekly. There's various protocols, but most of them involve coming in weekly for 30 minutes for 2 or 3 months. And then you do you're doing some maintenance schedule with monthly potentially. So I was talking about, the nerve stimulation I was talking about is sacral nerve stimulation, where you do an implant and it basically does the same thing, but it doesn't require the visits. Patients that have started with PTNS have not usually persisted. They usually at some point get tired of coming in and they stop, or they convert to a sacral nerve stimulator. Is there over-the-counter meds that would help with incontinence? I would say probably not. I think there's probably some products out there that would try to market themselves, and I doubt they would help. But I never say never though too. But over-the-counter meds, unfortunately, we don't get a lot of information on them. And also, what would you recommend on pads that will keep the vaginal area dry? Well, certainly keeping the skin dry is important, because if the skin gets excoriated, that causes a lot of problems. I'm not a big fan of diapers for treating incontinence. There's a lot of Depends tries with great effort to make it sound acceptable, but what I find is that 1, diapers are very expensive. 2, the skin does stay wet in many cases, and that creates other issues. So, but just regular pads are good for some people. You just have to change them frequently so that the area stays dry. Is there a difference if the symptoms of OAB start at a child? Sometimes that can be harder to treat. And again, when we talk about overactive bladder, I said it was a very complex condition, and there's a lot of, it's more than just the nerves acting up. There's a lot of learned behavior. And so sometimes when you have these problems since childhood, you've got some learned behaviors that go along with it. And sometimes unraveling those learned behaviors can be difficult, but not impossible. So in some cases, it can be a more challenging problem. I have had a Cystocele with anterior repair and a mesh. I need repair again, but I'm putting it off for now. I was sent to pelvic floor therapy in the past. I know that I shouldn't do squats or lunges. Are they good, bad exercises? Well, pelvic floor therapy, again, like I was saying earlier, it's meant to strengthen the muscles in the pelvic floor, trying to reduce the prolapse. And I'm not a big fan of telling patients they can't do things, exercises. I think being active and doing exercise is important. And whether you've had a repair or not had a repair, I'm not a big fan of telling people you can't do this or you can't do that. Can you treat both bladder and rectal prolapse during the same surgery?